Thank you for being back for the second part of the fluoroscopy workshop, where we're covering the details of image production. Again, my name is Michael Muehley, and as before, you'll find my contact information on the last slide, and certainly available for any questions you may have about this material. Taking a look at our roadmap again, we had covered radiation and images in our earlier lecture, really looking at image production now, then leading us into radiation measurements in biology, which are really the fundamental for protection, and then some details on the clinical use of fluoroscopy in pediatric medicine. Now, we have spoken about X-rays in general. We have so far not really spoken much about fluoroscopy. Fluoroscopy is really nothing but real-time X-ray imaging, where instead of a film or a static digital detector, we use a image intensifier, or nowadays also a digital detector, but something that is capable of giving us a continuous view of the X-rays that are hitting the detector. This used to be achieved using a phosphorus screen. The phosphorus actually interacts with the X-rays and creates a glow. You can see here in this picture this physician from 1917 during World War I, where he was using one of the early fluoroscopes to remove a bullet. And again, there's a theme here compared to one of the first clinical applications for X-rays. It's a little bit different. He was actually wearing a helmet that had the screen right in front of his eyes. And so he would direct the X-rays towards his body or towards his head. So those could hit that X-ray screen or the phosphorus screen that he's wearing. And he would be able to visualize those X-rays live. In the late 1920s, fortunately, we invented image intensifiers, which operate by the same principle, but are able to direct the image in a different location, and thus prevent having to have the operator being hit with the X-rays directly. What does the fluoroscope look like? So again, we have an X-ray tube, which is the source for X-rays, but then there are a couple of additional pieces in between the patient and between the X-ray tube and the detector. So we have the filters, which give us a much cleaner X-ray beam, and they're able to filter out some of those undesired non-characteristic X-rays. We have collimation, which allows us to shape the beam to the size that we need for whatever we're looking at. Obviously, the patient has to lie on a table that is radiolucent, so those X-rays can pass. Our X-rays then pass for the patient, and then may pass through an anti-scatter grid. The purpose of this anti-scatter grid is really to filter out any X-rays not coming on straight on, and then finally hits the detector. So collimation is really a set of multiple shutter blades which help us shape this X-ray beam. There's typical rectangular and round set of blades that can be controlled, and we can decrease the size, or we can cone down this X-ray beam to the area of interest, which allows us to reduce the amount of X-rays hitting the patient and ultimately reduce the amount of radiation delivered to the patient. But additional advantage is that there's less scatter production, and the scatter again is what hits the operator. And with less scatter comes also better image contrast. So it reduces the dose to both the patient, the operator, and gives us a better image. Another piece in shaping the energy of the X-ray beam is the filtration. So as we spoke about in our first presentation, the X-ray spectrum is quite wide, and there's a number of X-rays that do not help us actually create an image, that pass for the patient, may be absorbed, may be scattered, that are quite undesired and actually degrades the image quality while increasing those. Using filtration, we can add some kind of typically metal that has very specific characteristics as to what X-rays can pass. A very common one in typical radiography is aluminum, and aluminum narrows that beam and actually increases the average energy of the X-ray beam. So we remove X-rays of lower energies that are not useful to us anyway, and really overall then increase the energy of that beam. The results are we need less X-rays since we have that increased energy. We then decrease the effective dose because none of the lower energy X-rays get deposited in the skin and the patient. Again, typically we use aluminum for this, can also use copper, and we are talking about a couple of millimeters in thickness for these filtration devices. But ultimately, filtration does not occur just from the filter, but also includes the table itself, anything really between the patient and the X-ray detector is going to provide some degree of filtration. So we have to be careful in selecting the materials of those and make sure that we get the appropriate energy range for X-rays based on all the objects in the path to the patient. So we have now these great X-rays that pass through the filter. We only get the best quality of the X-rays. We make sure that we collimate as much as possible and really only let through X-rays to the areas that we care about, allowing us to reduce scatter. Now the X-rays hit the patient, yet there's still scatter. We cannot completely eliminate scatter because again, scatter is required in order for us to have enough interaction to actually get X-rays that we can use in the image generation. So one thing we can do is place an anti-scatter grid on the far side of the X-ray tube, which is essentially a little grid with straight spaced lines, typically lead strips. And that allows us to only accept X-rays that are coming straight on to the scatter grid. Anything that does not come straight onto the scatter grid will be ultimately absorbed by this lead and removed from that X-ray beam. This is not perfect. Anti-scatter grids do reduce some of the scatter and thus some of the noise, but certainly you can continue seeing noise with an anti-scatter grid. Unfortunately, introducing an additional device introduces additional problems. And so this is our first artifact that we need to be aware of that can occur with fluoroscopy, and that is the grid artifact. As you would expect, the grid artifact basically looks like a set of lines, just how the grid looks. And this occurs when the anti-scatter grid is not well aligned with the detector. So you actually may have this happen every once in a while if there's something loose mechanically. And the thing to do if this does occur is to contact your vendor and get the device serviced. So summarizing some of these image production techniques here, we have the collimation, which allows us to collimate or cone down the beam to the area of interest. Again, this is good because it reduces the exposed tissue, gives us less scatter radiation, which ultimately results in better image contrast and lower dose to the patient and the operator. We have filtration. These filters are usually made of aluminum, sometimes copper, sometimes other materials, and they're located in the path of the primary X-ray beam. And the job of the filter is to remove the lower energy X-rays and really create a more uniform X-ray energy beam. Again, lower energy X-rays are not really of interest to us in image generation. They get absorbed in the tissues, so they generate patient dose, but we don't need them for imaging. So if we can filter out as many as possible, we'll get a higher quality image with lower dose for the patient. Last, we have this anti-scatter grid, which is on the far side of the X-ray tube. And this is really there to remove any scattered X-rays. Again, scatter is what generates noise. So by removing scattered X-rays, we get that noise. But do remember that you can get this grid artifact, which is a mechanical problem with how the scatter grid seats in the detector. taking a look here at a C-arm fluoroscopy unit or a mobile fluoroscopy unit. In radiology in the department, we actually have fixed units, which are typically used for GI indications, allowing us to deliver more and more precise radiation. But this is your typical unit that you would find in an operating room. I know many of you actually use the smaller units, which are primarily useful for extremities, but the components remain the same. We have the C-arm, and then on one end is the image intensifier, although many times today that's going to be an image panel or a digital detector panel. On the other side, we will have our X-ray tube that delivers the X-rays. There typically is some kind of image display, some kind of image storage device, units that goes along with the C-arm. Although this does appear to be a couple of years old, and most of the ones today are actually a little bit smaller. So here, another larger fluoroscopy device, C-arm, and then one of those extremity C-arms that are quite often used in podiatry. You can actually see on this smaller device here, there is something called a comb, which is installed by the manufacturer. It gives us a minimum distance from the X-ray tube. So you should never remove those X-ray cones. You may be wondering, why isn't there such a cone on the larger unit? And just because of the way that the unit is designed, it's a larger unit. The cone is actually built into that inferior aspect of the C-arm. We are here actually looking at two different types. The larger unit here has an image intensifier, whereas this smaller unit is fully digital. So the acquisition of the X-ray image is digital, and it's fed into the device digitally as well. We have the image intensifier on the one hand, which again typically traditionally used to be a phosphorus screen, which was captured. And then we have the flat panel array detectors, which are the fully digital ones where there's no more film in between. You can recognize which type you are using by taking a look at the shape of the image. If you're looking at a round image, those are typically image intensifiers. If you're looking at a square image, those are always flat panel array detectors. So looking at the image intensifier, it is the piece that converts the X-rays to an image and amplifies the brightness of that image. The X-rays themselves to ultimately not generate a lot of brightness when they hit the phosphorus. So we do need to amplify this. It's kind of interesting looking at the image intensifier. It's a little bit the opposite of the X-ray tube. What we have here is really a layer of the phosphorus, which is at that input window, where the X-rays get converted back into electrons. And then those electrons go towards the output window or the focus there. And similarly to a cathode ray tube TV, we accelerate those electrons to really hit that one specific point, which is the output layer. Now that output layer, back in the day, people peek into the hole and see that image that was generated from the electrons. Still not ideal, because ultimately the X-rays are hitting the detector. You're going to be right behind that detector, although you're not looking at the X-rays directly. You're looking at the converted electrons. Nowadays, obviously, there's a video feed that is taken at that output window and fed into a TV monitor. Or in the case of a digital acquisition, none of this applies anymore. With the flat panel detectors, there's actually two types as well here. But what we want to do with this is converting X-rays directly to a digital signal. And so there's the one type, which essentially is a computed radiography flat panel, where the X-ray continues to hit some kind of chemical, typically cesium iodide, that generates light when hit by an X-ray. And that is then converted to a digital signal using a second panel, which can then be fed into any other area. The other way to do this is actually to use a silicon-based detector that can directly generate electricity from the X-ray hitting it. I'm personally a big fan of anything we can make digital in radiology. I don't think I would have become a radiologist if we were still using film like in the good old days. Just seems very unwieldy to me. And yeah, I do think that the digital technologies in general are better. They are much more reliable. They don't break down as much. There's much less mechanical that can occur with a digital approach. The downside, of course, newer technology. So these are more expensive compared to the traditional image intensifiers. We briefly spoke about the X-ray machine actually adjusting itself to deliver the right amount of uh, X-rays and the right amount of energies. And in fluoroscopy, this is called the automated exposure control. In phototimers, the machine can actually calculate how much X-rays and what energy X-rays to deliver. And most fluoroscopy units today are operated using this automated exposure control in a mode called automatic brightness control. So if the image does not appear bright enough, this ABC will increase the KVP, and that increases the X-ray penetration for the patient. And if that's not enough, then it will next adjust the MAS, and increase the brightness. So if you're looking at a area that is more to penetrate, thicker, looking at the abdomen, you will obviously require increased X-ray delivery, increased amount of X-rays, and that delivers increased doses to, again, both you and the patient. So if you're dealing with an obese patient with a very thick leg, that will not only increase the dose to the patient, but ultimately increase the scatter and increase the dose to you. This goes up exponentially, so any increase in thickness can quite significantly increase the amount of radiation that has to be delivered. So this is what a typical AEC, ABC curve looks like. The one thing that is difficult to change, the one parameter, is the filter that we use to filter the X-rays. So there's usually several different types of filters in any given device, and they can be electronically switched out. But you only have 4 or 5, 6 of those at your disposal, so the machine can change those, but that is going to be one of the factors that is most difficult to change. Tube voltage, tube current, and exposure time obviously can be dialed much more accurately electronically. So typically what happens is the filter gets changed if necessary, and then the tube voltage, tube current, exposure time gets dialed in. Sometimes you can actually hear that pre-filter change, and there can be a little bit of a click coming from the X-ray device. And that tells you that the whole energy state that is going to be delivered is quite different. When taking a look at the image, we have a concept called the field of view, FOV. This is actually different from magnification, which a lot of people get this confused. You can have a field of view that is as large as your detector, and then you can actually decrease your field of view by decreasing collimation. It essentially is just the area that you're looking at of the body. And again, you are limited to the maximum size of your detector or your film. Now we're looking at the projection of the object. So this is, again, very analogous, and a lot of things in radiology, or at least X-ray physics, are very analogous to photography. We have the source, which is in this case the X-ray tube. We have our object in between, which is the patient, and then we have the detector at the end, which is where those things get projected from. The source is generally a point source or close to a point source, whereas we're imaging something that's much wider and ultimately need to project onto a larger detector. So this gives us the concept of the source object detector relationship, and that can actually quite vary how magnified our image is. Now, if I want to magnify the object more on my field of view on my detector, what I can do is actually decrease the source object distance, bring the object closer to the source, and what I will see is an enlargement of the image on the detector. So one thing we want to do is change the beam as little as possible once it leaves the patient. And positioning has a pretty significant impact on this projection. So the farther away we are from the X-ray tube, the less distance the beams will have to diverge onto the image intensifier or detector. Uh, the other piece to this is that we can use lower exposure if we are closer to the image intensifier because we're going to lose less X-ray once they exit the patient. So improper technique is really being placing the object of the patient very close to the X-ray tube. What we do want to do is bring the detector as close as possible to the patient. Side effect there is that we actually get a sharper image if we do so. The divergence of that X-ray beam onto the detector also creates blur. So again, only positives in relation to bring the patient closer to the detector. So as we talked about, we can change the field of view, but the other thing we can do is actually magnify. So by varying where exactly the object lies, we can create an increased image of this object. And so sometimes we use that to enlarge portions of the image while maintaining the output size of the image the same. We increase the resolution, but the downside is we do increase the effective radiation dose because we do need to deliver more X-rays to this smaller area in order to get the same image. Now, our typical fluoroscopy device has different modes. One of these modes is pulsing mode, which if you want live X-ray is the best way to obtain those. What happens here is that depending on the number of frames, you shoot a certain number of X-rays or fluoroscopy images per second, which gives you the appearance of a live image, right? I mean, it's just like movies where you need about 25 frames per second in order for them to look fluid. Now, we typically don't need a super smooth video with fluoroscopy. So typically we want to decrease the number of acquired images. And typical setting is around 15 pulses per second, even better 10. Again, the downside is we are getting more X-rays, so we are delivering a lot more radiation. There's also something called the continuous mode. Essentially, what that does is it keeps the X-ray tube open and continuously acquires an image. Obviously, even more X-ray exposure to that, the increase in radiation dose is actually quite significant in comparison to pulse mode. So you really never want to be using continuous mode. I'm not really sure if there are any good clinical applications where that would be required. A traditional image intensifier can actually give you a wide variety of artifacts, and artifacts in radiology are always a great test question. So you certainly want to know what these different ones are. One is the pincushion distortion, which is basically due to the shape of the image intensifier. Quite often we see vignetting, which is a darker edge of the image, which is due to the way that the phosphorus is layered. We see something called S distortion, which if you've ever held a magnet close to a old cathode ray tube monitor or TV, you will also have seen that, but it's basically the distortion of the way that the electrons hit the image intensifier. And then something called lag, which basically is the low frame rate that you may be obtaining with pulse imaging, but you can essentially see the prior image on the new image that way. Again, something that only occurs with pulse fluoroscopy. All of these artifacts are really only relevant for image intensifiers and do not apply to flat panel detectors. Those have their own set of artifacts, of course. We don't get vignetting, we don't get distortion in flat panel displays, flat panel detectors, but what can happen is actually dead pixels. So you may have one of those pixels that is no longer functioning, and that just generates either a white or a dark signal. And it's very similar compared to your LCD screen. So most LCD screens are typically delivered with one or two dead pixels. And if you were to closely look at your LCD screen, you may be able to find those as well. And so the same thing can happen with a flat panel detector. Again, most of the time it's not going to be noticeable. It's not going to be a problem. If you do have a larger number of dead pixels, that is something that certainly could be rectified by the manufacturer. So as for C-arm operation, all fluoroscopes are actually operated by a foot pedal, and that is a regulatory requirement. And this pedal is a dead man switch, so the machine will only operate when there is pressure on the switch. So if you do die while operating a fluoroscope, you're going to release your foot pressure and spare all the others. Now, positioning is very important when operating a fluoroscope. The most important thing you can take away from this is that the X-ray head should always be positioned under the patient. You should really never put the X-ray head above the patient or really above the table. The X-ray source really should be about 12 inches away from the patient's skin. And again, most C-arms do have a spacer cone to keep that right distance already in place. We'll be taking a look at some of the reasons for why you want the X-ray arm, the X-ray tube under the table in a little bit in one of the next lectures. As for C-arm positioning, so yeah, there's two ways how you can move the C-arm, and that is important when you're communicating with a radiology tech that may be helping you with the exam. You can either move the entire unit or you can only move the C-arm. You can do something that's called cant, which is move the angle or angle the base cephalad or caudate, and then you can see over, which is moving in plane of the C-arm, which you need to do when you want to acquire lateral or oblique views. Again, if you're operating one of the smaller units, you may be able to do this yourself, but very often with these larger units, you need to have an assistant, typically that's going to be your radiologic technologist.